Can anybody hear us in the actual room? Sorry for the wait, everyone on Zoom. Everybody on campus is working on getting the volume set up.
Brittany, can you hear us?
Yes, I can hear you now.
Okay, perfect.
Okay, yeah. There is a little bit of echoing though. But I think in the meantime, we can go ahead and get that.
Okay, can y'all still hear us?
Yeah, that's much better. Can everybody, can you guys, so on your end, Abigail, can you see the Zoom on the big screen?
Yes.
Okay, do you want to put it in like gallery mode and then everybody in person can stand in front of the Zoom so we can get a big group picture? And then if everybody on Zoom, if as many people as possible could turn off their cameras for just a minute so we can do a big group picture.
Can you go over there and just so you can turn that off?
We have 40 people here on Zoom, so that's great turnout.
Wonderful.
I'm assuming a lot of people are here from the Temple campus, which is exciting.
Can everybody hear me okay?
Yes, we can hear you.
Excellent. Did you want me to just start, or do you want to wait a moment?
Do y'all want to do that picture first?
Whatever you think. That would be great.
Yeah, if you guys in person could like stand in front of the Zoom gallery and get a big group picture. Zishan had messaged me about needing a picture for the.
I see. I don't know how to do the Zoom gallery.
Like, so if the Zoom is up on the projector, is Abigail there? We can do it afterwards if we need to just get started since we're running late.
Okay, we got about 2, 4, 6, 8, 10 faces so far, but there's about 12 that aren't showing their faces yet.
That's okay. We could just take the picture and then.
Sounds good.
Yeah. And then maybe if somebody in person could turn their Zoom on to face you so that everybody in Zoom land can see you as well.
Did you catch that? They want to turn the Zoom on so I can be seen. I don't know if this one will work. Is there a way to turn on maybe the Zoom on this computer so my face is visible?
Here, let me text Abigail.
There.
While she's getting that, oh, I can see you guys.
There I am. All right.
Yay! Awesome.
That's
Perfect.
Sorry to be so towering here, but
Yeah, sorry everybody for the delay. Let me do a quick introduction for Dr. Dubay. Elmig is really excited to have him visit us. He is visiting us from the Physicians Committee for Responsible Medicine, and a little bit of background about Dr. Dubay. He loves hiking, animals, camping, and promoting lifestyle medicine. He formerly has served as a clinical assistant professor of medicine at both Michigan State University College of Osteopathic Medicine and the University of Michigan School of Medicine. He was also the associate program director and led the lifestyle medicine resident curriculum and scholarly activity programs for 30 IM residents at McLaren Greater Lansing. So with that, whenever you're ready to get started, Dr. Dubay.
Thank you so much, Brittany. Thank you, Austin, Cantu also, and everybody else who helped get this started. I'm really honored to be here. It's you guys have a great reputation. So what can I say? It's an honor to be invited here. Thank you. I can also say how honored I am to work with PCRM, Physicians Committee for Responsible Medicine. They do, Dr. Neil Bernard runs the program. It's a nonprofit. They do all kinds of great medical research, medical education like this. And it's, like I said, a nonprofit. So, and they'll have great resources if you go to their website for yourself and for patients. So what does lifestyle medicine look like in practice? Let's talk about a case study. I met Jean a couple years ago in our internal medicine clinic, resident clinic. She's a 58-year-old woman at the time with severe peripheral vascular disease on high-dose statins. She had had a previous history of aortobifemoral revascularization in 2018. She had worsening renal insufficiency, but was not yet on dialysis. Her claudication was quite severe, 1 block before she gets severe pain in her lower extremities, and was worsening. So our assessment at that time was worsening peripheral vascular disease, worsening symptoms, despite, in quotes, maximal medical management. That's what her physicians told her. Her surgeon was recommending repeat revascularization. The nephrologist offered no further treatment to arrest progressive renal failure. Our plan at the time was to recommend immediate transition to a whole food plant-based diet with group support. Why group support? Does that help? Why group support? What is the best tool we have in lifestyle medicine to help people make lifestyle changes? The most effective tool. If you guys can raise your hands or just answer out if you like, but that tool is group education, group meetings. We call it intensive therapeutic change, lifestyle change, ITLC. So we set up a program at McLaren where our residents would rotate in groups of 4 and run our ITLC group. It was in collaboration with our cardiac rehab, similar patients, but we made it free. We made it open to anybody, whether you had disease or not, go there for prevention also, and to address people who have issues with access, right, or education. We need to make sure we include those people. You put it in a location where people can get there and you make it free. And we told her to hold off on surgery. She was scheduled for surgery, as a matter of fact. Now, we saw Jean in follow-up, but she actually called me a couple months ago, and she said that her symptoms continued to improve on her whole food plant-based diet. And I will mention that a lot of people need a lot of help, and they need the group support, but Jean was so motivated. She had talked to her other physicians about starting plant-based, and they made comments like, what about getting your protein? So she was frustrated and she found us and sought us out because she was so glad to find physicians that understood lifestyle medicine and nutrition therapy. She had just had ABIs, ankle brachial indices, which showed that her blood flow in her legs was improving without revascularization. Her kidney function was stable. And her surgeon and nephrologist were surprised and couldn't understand why she improved. Why couldn't they understand? Because your mentors, the physicians that trained before you, myself, none of us were ever taught any of this. You guys are one of the first groups to really go through and have an opportunity, if you choose it, to learn lifestyle medicine. So you guys are here, so you're way ahead of the game. Good job. Let me talk a little bit about scholarly design as a background. Now, we all know about the randomized controlled trial. It is one of the great accomplishments of 21st century medicine. With the randomized controlled trial, we can prove causality with a high degree of certainty. And in practice, I can see a good randomized controlled trial and change my practice overnight, especially if it's from a reputable group and it's been repeated by a second independent research group. So it's very powerful. And we've been discovering new treatments with the RCT almost daily, probably daily. Do you ever turn and ask yourself, how's that working for you? Well, let's take a look. Well, the CDC tells us that almost 11% of our population has diabetes. More than a third of our population has pre-diabetes. And if you look at the trend, those numbers have been rising for decades. And we know one of the major risk factors for diabetes and many other diseases, including heart disease and depression, etc., is obesity. Back in 1960, 14% of our population had obesity, and now we're at well over 40%. That's a BMI greater than 30. So somewhere we're going wrong as a medical community. We're not doing our job, in my opinion. We're failing our patients and our community. The problem with the gold standard in medical research, the randomized controlled trial, is it's easy to conduct on pharmaceuticals and procedures, but it produces a bias in physicians towards treatment with pharmaceuticals and procedures, and often leaves the underlying cause of disease untreated. That's a big problem. Other research, let me ask you a question. How many of you believe that smoking causes heart disease and lung cancer? Just raise your hands. We all know that. It's fact, right? How many RCTs are there on smoking? I don't know of any. We can't do that. It's unethical. So you need to be able to interpret, and it's more difficult, the non-RCT data to make good decisions as a physician. Okay, now this is a quiz question. I wish it was easier for me, but for you remote people, but there is a nutrient deficiency that affects more than 90% of Americans. It's associated with higher rates of heart disease, diabetes, obesity, some cancers, and more. This is an epidemic of a deficiency. This is malnutrition in our country. How many of you think you know what that deficiency is? Go ahead and raise your hands. Not sure, and that's okay. That's okay. And that's typical. How about fiber? How about fiber? Even the USDA admits that 90% of women and 97% of men are deficient in fiber. We don't eat enough fruits, vegetables, whole grains, which includes beans. And it's deadly. We're good at replacing deficiencies, but not when it comes to fiber, for instance, or how about phytonutrients? All right, this is a study I think all medical students should have seen by now, and I don't know of any that have. But this is something that should be taught, and you certainly should see it by your residency. The Global Burden of Disease Study. This is the U.S. state of health. So it's just the U.S. data in this publication in JAMA 2018. It's touted as the most rigorous analysis of risk factors ever published. It was funded by the Bill and Melinda Gates Foundation. And one of the major findings is that the #1 cause of death in the United States and the major cause of disability in this country is anybody. What do you think is the risk factor that kills and harms more Americans than any other risk factor? Pardon? That's an endpoint, but what is the risk factor that causes that heart disease? That's a good answer. How about our diet? Our diet, yeah, but that's a risk factor, definitely sedentary lifestyle. We'll mention that in just a second. And hyperlipidemia also, we'll mention that in just a second. This has now bumped tobacco smoking to number 2. Tobacco smoking kills about 500,000 Americans every year. Every year, about 3 million Americans die, and 500,000 of those are caused by smoking. Our diet now kills not thousands more. I'm going to show you why it's hundreds of thousands more. So, standard American diet is killing people. A lot of people. So this next 2 slides are the top and bottom of a single page. So the legend on the right is continued. What I want you to focus on is the bars here. So this bar here for diet or for tobacco, you can see it is number 2, and it's about 500,000 deaths in the year of this study, 2016 here. There's diet, number 1, slightly more. But let's look at the next 4 risk factors. High blood pressure, high body mass index, right, of being obese, high fasting blood sugar, high total cholesterol. Somebody mentioned that as a risk factor. Now, those 4 are caused partly, and some of them mostly, by diet. So when you add up the contributions to diet from those, you can see that of the 3 million deaths that occur every year, probably more than 50% are just our diet. And there's alcohol and drug use, low physical activity that we just also was mentioned. So they're also important too, and those are all part of lifestyle medicine. People say about 80% of deaths and disability are attributable to lifestyle factors. And this is similar, but it's about disability adjusted life years. Very similar, even though diet's number 3, when you add in all the other factors, it's clearly the number 1 cause of risk factor for disability. So you're going to go through all kinds of medical education here at your medical school. You go to a residency, maybe a fellowship. Who is requiring you to learn about these things? That yes should be on the right. I apologize for the slide. No, you're going to eventually take the USMLE or the COMLEX, right, to get your license to practice medicine. Guess what? Those exams don't have a single thing. I know this for a fact because I've asked lots of students after they've taken it, when they come to our residency, if it was on there. And your school is not teaching it because your school needs you to pass that exam. So your school doesn't have this as a core curriculum, what should be the foundation of all medical school curriculums, because it's not on the exams you need to get licensed. And then you'll go on and you'll take internal medicine, family medicine, OBGYN, or surgery too. Again, those board exams, I just retook the internal medicine boards a few years ago. They don't contain anything on what you're about to learn today. Who does require education on healthy diet? Well, of course, it's the American Board of Lifestyle Medicine. You take a lifestyle medicine residency curriculum. Some residencies have it, some don't. This is the message of the day. You absolutely have to find a residency that has the LMRC. A few do. It's expanding rapidly today, but they don't all have it. And if you don't go to a program and get board certified, you become board eligible, then you take a board, like I did. If you do not become board certified in lifestyle medicine, and when one of your patients asks you, doctor, physician, what is the best treatment for my disease? Now, if it's diabetes or coronary artery disease or most of the other obesity, most of the other chronic diseases we see, you're going to have to say to them, well, the best treatment to treat the underlying cause is nutrition. But I'm not qualified to talk about it. You can't go through your career saying the number 1 cause of death and disability is something you're not qualified to talk about. So you must get board certified in lifestyle medicine. These are the other pillars of lifestyle medicine. 25% of the curriculum is whole food plant predominant eating pattern, whole food plant-based eating pattern. So when you're done, when you go out and practice, you should be sending your patients to the pharmacy with the F, right? Way, way more than the pharmacy with the PH, because that's what's going to keep them healthy. Not that the rest is not important. It absolutely is. We can't treat everybody. If we can get well over 50% with lifestyle, then we don't need to use all those drugs, which I'll touch on in a minute. Okay, but don't believe me. Let's look at the peer-reviewed medical literature. I only want to expose you to a few landmark studies. Maybe you've been exposed already. Please, if you've been exposed to something, raise your hand so I can see that you guys are seeing some of this stuff. I don't expect that you have, but these are studies that have been around for years. We've known this stuff for a lot of years. Just as a little background. Now, let's say you want to do a research study and you want to do a power analysis. How many subjects do I need to reach statistical significance, right? Well, one of the things you need is the incidence of the outcome. Let's say the disease you're looking at is a really sick population with coronary artery disease, and you expect in the next 3.5 years that about 50% of them are going to have events, some kind of cardiovascular event. Let's say you've got this intervention that you want to test, and you're confident it's almost 100% effective. How many subjects do you think you need in that scenario? Very high incidence of outcome and very effective intervention. Anybody take a guess? Is it 10, 100, 1,000? What magnitude? 10,000? Go ahead.
1,000.
It's actually closer to 10, right? Tens. And one of the things you know is, so a small research studies, because they have the power to detect very effective outcomes, demonstrate the most clinically significant interventions, right? Because what you always want to look at is the number needed to treat, an NT. So if you see a study and you're always saying, oh my God, that study has 10,000, 100,000 patients or subjects in it, that must be a good study. The first question you got to ask is, what's the number needed to treat? Anybody guess what the number needed to treat is for this study? I don't think I said it yet. It's 2, right? Because if you got 2 patients in your study, you expect one of them to develop the disease over the next years, and your intervention's 100% effective, right? If you treat 2 of them, this guy wasn't going to get the outcome. This guy or woman was, so you prevented 1 outcome just by treating 2 patients. If you look at, for instance, using statins in primary prevention, a lot of physicians believe that that is not warranted. The reason is because the number needed to treat is so high. Statins are only 25% effective in preventing cardiovascular events in secondary prevention. And so the number is so high and the side effects are so numerous, right? It's not worth it. But the drug companies know how to get us to think it is. It's used a lot. So Dr. Esselstyn, he knew all this a number of years ago, and prior to this study, he had treated a lot of people with nutrition therapy, a couple dozen, and he had shown that with more than half of them, he could get their angiograms to reverse. The only thing actually opening up coronary arteries that are stenosed with atherosclerosis. And so at this point, he became pretty well known at the Cleveland Clinic. He had patients calling him all the time. Dr. Esselstyn, I have heart disease. I don't want to die. Can you help me? Yes, I can. So he got 198 consecutive patients who called him. They were interested in plant nutrition. These are motivated people, plant-based nutrition therapy. So he counseled them intensively. And at the end of 3.7 years, 89% of them were adherent. So here's the important thing. If his patients, he asked them one single question. Have you eliminated dairy, fish, meat, and added oil from your diet? If the person said yes, that group, 177 people, had one event, 0.6% incidence of a cardiovascular event. So that's almost 100% effective, right? 99% in this study. Not a big study, but when you look at, the control group, not the control group, the people who answered no to that question. This was not a randomized controlled trial, but the people who did not follow diet, 62% of them had adverse events, including MIs, stents, revascularization, attributable to their disease. Now, if you have your patient and their coronary arteries are inflamed, on fire. And you're pouring gasoline on, right? You're adding inflammation to the fire. You can throw as many statins and stents and drugs, and it's going to re-stenose. They're going to have more disease. You got to turn off the gasoline. And what is the gasoline that fuels the inflammation in our bodies, including in the coronary arteries? The American diet. Plant-based diet, the whole food plant-based diet, is anti-inflammatory. We can show that with markers. Esselstyn has shown that. There's a lot of research. This is just tip of the iceberg. Dr. Esselstyn would say, well, if you're treating coronary artery disease, but I would add diabetes, hyperlipidemia, obesity, and many more of our chronic diseases with just drugs, angioplasty, stents, surgical procedures, you're not addressing an underlying problem. You're practicing palliative care. Palliative care is like a cancer patient who we have no treatment for the cancer, so we just help them feel better as long as we can. We're not addressing the underlying problem, but we do have tools today for most people with the chronic diseases we just saw in the global burden of disease study to treat and prevent and even reverse their diseases. So you have to do that, or you're just palliating. He'd even go so far as to say, there are two types of cardiologists, or just two types of physicians, those who eat whole food plant-based and those who have not read the medical literature, which is the majority of us out there now, right? The majority. It's very similar to smoking in the 1950s and 60s. A lot of physicians smoke. There's never been a single study. I'm going to get to that in a moment. So what now, based on the research you've seen and thousands of research articles that support this approach, is the ideal intervention for coronary artery disease? Whole food, plant-based nutrition, low in fat. Dr. Esselstyn also had his patients avoid high-fat plant foods, which are nuts, seeds, avocados. That's the only difference. Avoid processed foods, especially oils. They're actually they're toxic to the endothelium of the coronary arteries. Avoid animal products. They're neither necessary nor beneficial to human health, and there's much evidence that they cause harm. So yeah, this is what the diet should look like. You can certainly cook these things and blend them and mix them, but avoid, for coronary artery disease anyways, nuts and seeds. Lots of herbs and spices. Well, they're not really magic beans. They're just a heck of a lot better for you than meat and dairy. Now, you guys may or may not be able to see this, but the date on this is 2003. None of this is new news. Who has seen or read or studied the Cornell, or heard of the Cornell China study? So this is a famous study and there are books written about it, but Dr. Campbell and his colleagues, they went to China. This was published in the American Journal of Cardiology in 1998. There's more papers on it. This is the cardiac version. And they looked at mortality data for all kinds of diseases in 130 villages in rural mainland China. And then they compared, I'm sorry, my slide is not showing up how it does on my screen, but let me go through it. They compared the Chinese diet with the US diet, and you can see in the US, 36% of our calories come from fat. In China, much less, 14%. Animal protein, 70% in the US, in China, 11%. But 130 different villages, some of them ate a lot more than that. Some of them ate close to zero, right? Or maybe zero. And then fiber, 25 to 30 is the US RDA for fiber. That's actually a low number. Here in the US, 11 grams of fiber. So we're very low in fiber. The Chinese, they get enough. And then they looked and saw, well, what's the incidence of coronary artery disease mortality? Much, much higher in the US, as expected. And it correlates with the animal protein, quite honestly. Now, another thing they noticed is when they looked at the trend, it's not statistically significant, but the trend of those villages where they ate more animal protein compared to those that ate less, there was no threshold where you ate less animal protein where you didn't get more benefit. In other words, the question is, well, is there some point where we need animal protein? When you go below that, you're going to start having problems. No, not in this study, not any study I've ever seen. And I'll give you a chance to Tell me if you know of one. Obesity. I'm going to go through these a little bit fast. I just want to expose you to them. PCRM. Dr. Neil Bernard did this study at a Geico corporate site. They taught one group, their intervention group, a plant-based diet. And you can see that they had a 11-pound sustained weight loss over 1 year, whereas the control group that didn't get any education, didn't lose any weight. This study I love. This is a randomized controlled trial. This was done by Nick Wright and his colleagues in New Zealand. I've even spoken to Nick Wright about this study. And 65 subjects randomized, facilitated meetings twice weekly for 12 weeks, non-energy restricted. This is not a diet where you have to count calories. You go on whole food plant-based, you eat as much as you want, whatever you want in the diet. And their results were, they also gave them B12. 4 BMI points lost more than the control group at six months, and it was sustained. 4.2 BMI points lost at a year, held up, which is about 20 pounds depending on your height. But what they noticed, or they claim, is to the best of their knowledge, that research achieved greater weight loss at 6 and 12 months than any other trial that did not limit energy intake or mandate exercise. You can lose a lot of weight. It's the ideal way to lose weight on a whole food plant-based diet. This is what they used, just a red light, green light, traffic light to tell people what to eat. And if you look at the red light, it's poultry, fish, meat, eggs, dairy, and oils. Same as Esselstyn. They also said avoid high-fat foods, nuts, seeds, avocados, and coconut. This is the same as Esselstyn. Super greens, eat these every day. These are cruciferous vegetables mostly. And they seem to have extra properties that really can benefit us. They asked these people at 3 months, the people in the intervention group, in the last 3 days, have you had any indiscretion eating something in the red group? The people who said 0, look at, they lost between 5 and 6 BMI. So very effective, especially if you're adherent. COVID, who would think COVID? Let's look at COVID. If you added COVID to that first slide with roughly 3 million deaths, before COVID, this was just before COVID, just under 3 million deaths. During the peak of COVID, about another 500,000 deaths from COVID. Okay, that'd be another bar in that chart. But what does COVID do? This is the first smartphone-based study I've looked at. Almost 600,000 participants, US and UK. They looked at a score, a diet questionnaire, food frequency questionnaire for a plant-based diet score. Did it prevent COVID? Not much. The hazard ratio is 0.91, maybe 9% less COVID, or maybe it was more subclinical COVID, right? But who got severe COVID? Well, if you ate a plant-based diet, 40% less COVID. Hazard ratio of 0.59, highly significant. So even if you get COVID, even if we had to, we could prevent a lot of that with just eating healthy diet. I think I missed one thing I wanted to mention about Nick Wright's study. They also did a questionnaire on how much do you enjoy your food? And they asked people before and after going plant-based, and they asked the control group. Guess what? They all enjoy food equally as well. Most people think, oh, if I give up my cheeseburger and my Doritos, whatever, I'm going to be so unhappy. That is one of the many myths about this that we have to dispel, because you will enjoy food just as much after a transition. I don't know, a month, 6 weeks. This is another study, similar healthcare workers, web-based. Again, I don't know why it doesn't show up as well there, but plant-based diet versus everybody else, odds ratio of 0.27. That's about a 40% reduction in moderate to severe COVID. If you add fish, pescatarian, they are plant-based with fish. Not statistically significant, but doesn't seem to be as beneficial, right? The odds ratio is a little higher. And you've heard of the low-carb, ketogenic diets, right? Well, when I started practicing, we didn't know. People lose weight on them, 10, 20 pounds typically. We didn't know if they were harming them or helping them. Well, now we know. They're not healthy. And this is just another evidence where if you were on a ketogenic diet when you got COVID, you were worse off than the American diet, right? So not a healthy diet, not something we should be telling people to do. We should tell them not to do it. I mean, I don't want to die early, but I definitely don't want to live 20 years with dementia, right? What can we do about dementia? This was a great study. 2,258 community-based people in New York, Medicare. So they're 65 and older, and they have no dementia. They did a Mediterranean diet score, Medi-score. Mediterranean diet is mostly plant-based. It does contain some fish, very small amounts of meat. 262 incident cases, that's like more than 10%, right? Following them for an average of 4 years. But dementia can get pretty prevalent. They adjusted for a number of risk factors, and they found the people with the highest Medi score ate the most plant-based diet, 40% reduction, hazard ratio, 40% reduction in new onset dementia. And there can be a number of reasons for that, from anti-inflammation, anti-atherogenic. There's a lot of things we don't know about the cause of dementia yet. Depression and anxiety. Neil Bernard, also with PCRM, did this study on multiple Geico sites, almost 300 participants, overweight, not necessarily obese. This is a randomized controlled trial, and they taught them the same thing, weekly instruction on a low-fat plant-based diet. They showed improvement on a short form 36 questionnaire of symptoms of depression and anxiety, and their work productivity also improved. Food is medicine, prevention. People say prevention, an ounce of prevention is worth a pound of cure. Oh no, it's worth far more than that, all right? Far more. We know what it is to treat these people that finally get these diseases. And we know with cardiovascular disease, probably close to 99% or 100% effective. We talked a little bit about diabetes, obesity, not hypertension yet, depression, a lot of our chronic diseases that we see. I find this really interesting. Anybody interested in GI? I saw these physicians talking about HMOs, not those HMOs, human breast milk oligosaccharides, the third most prevalent substance in human breast milk. And when they discovered that the infants did not digest this milk, they didn't absorb it at all, these HMOs, these oligosaccharides, they were scratching their heads. What's going on here? Why does the mother go through so much trouble to produce this and the infant doesn't even use it? And then they figured it out. That's equivalent of fiber. That is to feed the fecal microflora. It's so important, and it's important for their immune function. So this is a new field. This is an area we're learning something. We don't have all the answers yet. And we're learning that there's a lot of anecdotal evidence that some of our autoimmune diseases are related to poor microflora, right? They're even doing some diseases for C. diff, maybe you know something about that, doing fecal transplants because the microflora is so sick, has C. diff in it, there's not very much diversity. They'll do a fecal transplant, when yet, guess who has the most diverse, healthiest fecal microflora? Plant eaters, right? Eat whole food plant, eat fiber. That fiber deficiency makes your gut microflora sick. It doesn't have to be, and it may be causing immune problems, autoimmune problems. All right, let's switch gears just a little bit. Let's talk about the health benefits of animal products, meat, fish, dairy, processed foods, especially oils, in our diet. Can anybody name a study that shows why we need these or how they benefit us in some way? So I've been doing this for years, and I've been asking audiences, including physicians, medical students, a lot of residents. I don't know of any. I've been searching the literature myself. I don't know of a single one. You know what this slide looks like? If I put up the same slide and said, let's talk about the studies that show how smoking is beneficial, it'd be blank. Still be blank today. It's the same thing. But you might say, Dr. Dubay, what about the DASH diet? The DASH diet, stop hypertension diet, has been proven to lower blood pressure, and that contains meat several times a week. Well, Dr. Sachs, when he designed this study, him and his colleagues, they did a design study, which I'm going to show you one of the quotes from that. He said, the diet design goals were to contain enough animal products to make them palatable. Even Dr. Saxon, there's no benefit. There's nothing to suggest meat is important. But if I want to get people to eat this back in a few years ago, I better just put meat in there. Anybody ever see the movie with forget the author? When I'm up here, I forget his name. Jack Nicholson, and he says in the courtroom, "You can't handle the truth, right?" Well, I never recommend the DASH diet. I'm not going to lie to my patients. Tell them the truth. If I tell them to eat the DASH diet, I'm telling them meat's good for them, man. And we don't need that. And it also simplifies things too, right? I don't need to remember DASH, Mediterranean. There's so many out there. The gold standard is a whole food plant-based diet. Until we have better evidence, until we find otherwise. So when you go and take your lifestyle medicine curriculum, and you become board certified in lifestyle medicine, you won't be like one of these physicians back in the 60s who was recommending. A lot of physicians were recommending in the 1960s when we knew better, without any evidence, why don't you take up smoking to handle your stress? That was common. Today, we have physicians, we know you're going to see them oh, why would you want to do that? Where are you going to get your protein if you're not eating burgers or whatever? These are myths that we need to dispel. We don't want to be this guy in 20 years, right? You don't want to be that guy. We need to help people eat like this. So there's good information out there and there's bad information. Well, for forever, there's been a huge void in the media. Who should be putting out there what's healthy and what's not? Us, the medical community. But none of us know anything about it. Only a few. You guys are way ahead of the curve. Good job. How many of you think that you would, and I have in the past, recommend the American Diabetes Association diet to your patients for their diabetes? Yeah, I mean, seems obvious. They're well known, respected, maybe. I pulled this right off their website. Now let's take a look at this food. This food contains turkey sausage and turkey bacon. Those are processed meats. We know those are group 1 carcinogens. They cause cancer. Group 1 means we're quite certain as we can be without RCT, right, that they cause cancer. So this food contains two group 1 carcinogens. Look at the saturated fat. That's high. That's well over 10%. Cholesterol is high. Sodium is very high. And look at the fiber, 1 gram. That's not enough. And you also notice the background contains some fruit, which are not part of it. Why would they need to put fruit there? To make it look healthy, probably. So I would never recommend. USDA has similar problems. I don't know why. I do know that when they make their guidelines, the drug companies, the agriculture companies, they're all over there trying to, and they do effectively influence the process. So the My Plate, horrible information. Don't send your patients. Find good information for them, and you'll learn that through the ACLM. So where do you get good information from? And where do you send your patients? Not there. Look at the ACLM. There's lots of resources for patients too. This is like a summary slide. This is one of the key slides from the, I think it's 10 modules that you do as part of your training in LMRC, Lifestyle Medicine Residency Curriculum. And these are the elements of a successful diet. Vegetables, whole grains, fruits, legumes, beans, right? Those are the 4 food groups. Those are the 4 food groups today. Now, they have another slide that describes that. Stay away from processed foods, especially oils. Low salt, low fat. PCRM, I mentioned to you, they have a lot of patient resources. They have something called the Jumpstart program, 21-day Jumpstart. Patients can go on there and help them make the transition in 21 days. So they have a lot of resources. They have a new one, it's called Universal Meals. They're making menus for people with all kinds of gluten deficiency, all kinds of things that, nut allergy. Anybody can eat these meals, you know, almost anybody. And they look like this. So I mentioned lifestyle medicine. Make sure you go to LMRC. PCRM, you can just put in pcrm.org. Nutritionfacts.org. Has anybody ever gone there? Dr. Michael Greger? Yeah, it's good. So if you want really focused information, peer-reviewed, literature-based, You search on his website and you'll find something up on prostate cancer, for instance. And he has these 20-minute, probably 15-minute videos, hilarious, fun, fast, educational. And then you go and you click on the transcript, you can read it, and all of the articles he posts, just like I'm doing now, you can click on them and pull most of them up right there. All peer-reviewed literature. He's excellent. Code Blue. Now, I mentioned autoimmune diseases. If you had a treatment, we see people, the woman who made Code Blue was an infectious disease physician who early in her career got multiple sclerosis. And she basically became almost, I think she was wheelchair bound. She was in bad shape. And so she searched out and she found lifestyle medicine and whole food plant-based diet. And over the course of a number of years, she now runs marathons. And she's had plaques in her MRIs, not all of them, but some of them improved. This movie's about that. So there's a lot of anecdotal information out there. Is it proven? No, but if you have a patient who has a new onset autoimmune disease, lupus, whatever, we do know there's probably a link between Hashimoto's thyroiditis and milk products, for instance. So we're starting to understand that there's a link there, the immune system. Are you going to recommend a treatment which has no side effects, right? But it has many benefits, many preventative benefits. Seems to me like a no-brainer as a physician. You're going to recommend it anyways. And those people, it might help in rheumatoid arthritis, particularly. This is the ACLM, evidence-based, right off their website. Treat the underlying cause, right? That's what you want to do. That's what we do. That's why we go to medical school. No meat at all. Are you sure you're getting enough protein? Right? Gorillas, elephants, rhinoceros. Where do they get all of their protein from? Plants. So how can somebody intelligent say, well, if you're going to eat plants, where are you going to get your protein? I'm going to explain it to you in a minute. But that's a myth that's been debunked for decades. So that is a sign. When somebody makes that question or statement, that is a statement of their knowledge, their lack of knowledge about nutrition, therapy, healthy nutrition. They don't know anything about it when they make that statement. And that's okay in the general public, but when one of your colleagues or mentors says it, maybe you need to speak up and say, well, when's the last time you read the medical literature? Because we've known that's not true for decades. So a myth is something that is said to be, it's a lie, but most people believe it, right? It's prevalent, a myth. So let's talk about a lot of myths out there that a lot of people perpetuate because a lot of people gain from the American diet, right? Expensive, risky, dangerous, contraindicated. People are afraid to make the change. They're like, oh my God, is this going to harm me? What we have to understand is what is contraindicated for all the chronic diseases that we've just talked about so far and many more? The American diet. You shouldn't be eating that stuff. That's contraindicated. What's not contraindicated? Whole food plant-based diet. So let's turn it upside down. Expensive. My wife, we cook a meal, and my wife cooks all kinds of great food. But one of the things she did one time is made a pressure cooker meal. You can do it in a pot or a pan. Then we use grains and kale and whatever we want to put in there. Less than $1 a meal. No, it's not expensive. Could be, I guess, but usually not. Lacks protein, incomplete protein. Athletes need animal protein. I'm going to show you debunk that in a moment. Beans cause excess gas. Okay, let's say you're the typical American and your microflora is sick, right? Because you haven't been feeding it for decades. Now you give it a lot of food, a lot of fiber. Of course it can't handle it. It hasn't been handling it for decades. And so, yeah, you will get gas. Is the answer to say, oh, you shouldn't eat that? No, it's just the opposite. We need to get your microflora healthy. You need to slowly introduce whole food plant-based foods into your diet. Maybe take a probiotic for a month or something just to get your bacteria up to snuff. And then you eat beans and you won't have any problems. So these are all myths. Processed foods are necessary? No. Everybody says olive oil is good for you, right? Olive oil? No. We'll talk about that more. Deficient in many nutrients. No, there is one nutrient you have to worry about. You have to take a B12 supplement if you eat all whole food plant-based, unless You drink maybe plant milk. Some of them are fortified with B12. For myself, I've been eating whole food plant-based and my wife for over 5 years. And just plant-based, not whole food, for more than 10 years. And I've never taken a supplement until recently because we make our own soy milk now and it's not fortified. So once a week, you take a B12 and that's fine. Our ancestors didn't have to do that. Anybody have a guess why? Why did our ancestors get it if they were, maybe they're some hunter-gatherer, they were mostly gatherer? The soil, who said the soil? Yeah, exactly. And the dirt comes from bacteria, right? You get dirt in your food. Our food is so clean, we got to take B12. So when you hear your peers or your mentors, you're going to hear your mentors that don't know this stuff. Call them out in a nice way so you can still get maybe get a better recommendation from them because you know something and you teach them something. You need to read the literature before you talk. What's more dangerous than somebody? Let me ask this. You're going to learn a lot of stuff in medical school, but there's only one thing you need to know to be a great physician. That's your limitations, right? You know what you don't know. I can send you somebody who does. I'll help you. So we got to know our limitations. Well, if you go through medical school before today, back when your mentors did, we went through and we said, oh, well, we were taught everything important. We took nutrition. We learned about how vitamin deficient. We didn't learn much, I'll tell you that. So now you think you know something, but you don't. That's dangerous. And that's what you're going to find. A lot of your mentors, their knowledge is dangerous because they think they know something they don't. So this guy's been eating whole food plant-based for more than 10 years. He's a German guy who holds the world record, last I heard, carrying the most amount of weight. I think it's about 1,200 pounds for some distance, short distance. And you notice he says, I'm a vegan badass. So no, that's not vegan. So I could eat Oreo cookies all day long and call myself a vegan. I ain't never going to do that, right? That's unhealthy. But if you're plant-based and 3 or 4 times a year, you go to your relatives and you have some cheese or something, I'm still plant-based. I'm not a vegan because I ate something from an animal. And vegan is about no animals. Plant-based, about no processed foods and no animal products. We're limited, right? We keep it to a very minimum. A friend of mine did this. I'm going to try and wrap up sooner. We started a little late, so I'm sorry I'm a little bit over. In the yellow are whole food plant-based foods, right? And if you look at the nutrition information and you look it up, you can convert it to grams of fiber and grams of protein per 100 calories. Right there is the USRDA recommended. So 1.5 grams of fiber per 100 calories, got plenty of fiber. 3 grams of protein per 100 calories, got plenty of protein. Now, if you look at whole food plant-based, you could not become protein deficient. It would be very difficult. There's only one food in that list, and this list, it's not a complete list, that's low in protein. What is that? You guys see it? It's the banana. Right? Banana's a little low. It's got protein, not a lot, but plenty. It's got enough. So if you're eating all the 4 food groups, you eat fruit. Fruit is a little low in protein generally. You're going to have a hard time getting protein deficient. Look at things like spinach and cauliflower, kale, massive amounts of protein compared to your hamburger, 4.3. Why is it so low? Because most of the calories are fat. So if you're eating those Oreo cookies, yeah, you're going to have problems. Why? Because you're eating processed foods. When you process food, you take out the protein. Excuse me, you take out the fiber. But a lot of times, look at the oil and margarine is what I'm getting at. These are processed, these are ultra processed. No protein, no fiber, just fat. So why do people worry about protein in their diet, even meat eaters? Because they're eating a lot of this stuff. They're eating a very high fat diet. We saw that in the China study. And so, yeah, it's easy to get protein deficient. But when somebody's worried about protein deficiency, you're not going to see that in your patients much unless they're some terminal illness that causes malabsorption. What you're going to see a lot of causing illness in your patients is fiber deficiency. So turn that question on its head. Protein, you mean where do you get your fiber from? That's the important question. So who made this mess? You guys are going to have to seek out education on this on your own because you don't need to do this. You can get your license You can get your board certification in medicine or family medicine. You go on to your fellowship, and many of them learn nothing there about this. Whose fault is that? It's our medical boards. I've called these guys. I've written them letters. They don't get it yet. They're so behind the times. Hundreds of thousands of people in the U.S. suffer preventable death and disability every year. Their physicians were not required to know anything about the root cause of more than 50% of their diseases to get their medical license. To me, that's criminal. That's why I'm here. That's why I do this. Good. Call them up, send them a letter. I'm almost done here. Practice what you preach. That's Peter showing off our pantry before we sold our house. Lots of oatmeal, grains, whole grain rice, brown rice, that kind of stuff. This is something we make a lot. Once your patients hear this stuff, the first thing they want is a lot of recipes. They're gonna want recipes. So our group, that's what they do. They bring recipes and try them themselves. But hummus, the thing you'll notice about this hummus, we make this almost every day, every other day. Fresh hummus. There's no oil in it, right? There's no tahini, no oil. Everything you buy in the store, except for one brand, I don't know if it's around anymore, all contains processed oil. But you can make it yourself. We throw half a bag of chickpeas that's been pre-cooked, or a couple cans, in the NutriBullet, and add a little pre-mix of lemon juice and some spices, right? Including some chili powder and some plant milk. Blend it in 30 seconds, you got fresh hummus. And you can use this as a condiment. We make a cheese sauce out of it. It's very versatile. Dip. And that is where I'll end and take some questions. I hope I can hear people enough, but I want to thank everybody for coming, and thank you for inviting me. And I hope this was valuable. And please, if you want my slides or contact me, Austin and Brittany have my contact information. Thank you very much.
Thank you so much, Dr. Dubay. That was a wonderful talk and very enlightening. I really appreciated it. I guess one of my questions is, a lot of us are going off to residency next, and how would you, or do you have any advice on getting this kind of curriculum into your residency program?
Yes, I do, because our program where I was teaching brought it on while I was there, and I thought, oh my God, this must be expensive. Well, first, the director of your program, the residency, they need to integrate it in, they need to start it. Well, the ACLM, first, it's actually really cheap. For any entire program, it costs $1,500. Now, if your program you're going to can't afford $1,500, that's super inexpensive. So it's really easy to do. And they know that most of your mentors haven't learned this stuff. And so any physician who works on your residency and wants to can go through the LMRC with you and get board certified. That's how I got my board certification. I studied a lot of this stuff on my own before I came across the ACLM, which is really getting ramped up now because people are catching on. You can go to the ACLM website and see what programs actually have it already. Typically how it works, you go to, let's say, a 3-year medicine program. The first 2 years, it's a 2-year program. You do your concordant with your residency, you do your LMRC. It integrates into it very nicely. It's typically 1 hour, I can't go into too much detail, but 1 hour didactic per every 2 weeks, basically. Plus you document patients you see in the clinic, you do the group education. So there's a number of components to it. And then your 3rd year, you study for your internal medicine or family medicine boards or OBGYN boards. But you got to get the program to bring it on, or go to a place, tell them, hey, I want to come there, but you guys need to do this. Go to a place that already has it. Thank you, Brittany, for that question. Any other questions?
I think Caleb on Zoom had a question, if you want to unmute.
Hey, thanks for giving this talk today. I thought it was really interesting. So I've been on a high protein diet for quite a while now. And I know for bodybuilding, they often recommend that you eat about 1 gram of protein per pound of body weight. But I just wanted to know, I guess, what your thoughts were on what our protein intake should be.
So I'm not going to comment too much on high protein, and that level, gram per pound of body weight, is reasonable. And a lot of athletes unfortunately get this from supplements like whey protein and things, which is from milk, unfortunately, and those have bad side effects. Now you saw the athlete I showed you, and I have there are many other athletes who do this. You got to be careful. Too much protein is toxic to your kidneys, so you don't want to overdo it. I can't tell you an exact number, but there are many athletes. Matter of fact, there's one of the professional football teams. Most of their athletes, most of their players eat plant-based, and yeah, you can do it. You can easily do it if you want to train and body build. Sorry, I can't give you a little bit more specific answer than that, but thank you for the question. We have a question here too.
Yeah, first, thank you for. I just had a question about fatty acids. Are there any benefits to that?
So there is,
Could you repeat the question on the Zoom?
yes, thank you for saying that. I apologize, I didn't. Omega-3 fatty acids, are they important? Is there any benefit to that? Do we need to supplement that? So plant-based diet, no, if you're eating whole food plant-based, not a lot of processed, right? Not the Oreo cookie diet, you do not. But if you have some concern, and I admit my wife and I, walnuts, flaxseed, chia seeds, those will give you the omega-3s you need. So if you want to take a teaspoon of that, put it in your oatmeal or something, you can do that. Little controversy, are you going to get enough if you don't do that? Most physicians don't necessarily recommend it. You saw Nick's diet, they gave the B12, but they were not, there was one thing, if you're concerned, go ahead and do that. So that's what I recommend. Get them on the plant-based diet first, then tweak it, is my advice. Does that answer your question?
Yeah, I guess it was like also kind of referring to fish, because in your presentation you talked about kind of how fish as well as
Other meats. Yeah.
other meats. So I guess like what is the main negative associated with like pescatarian diet?
So I showed how adding fish to the diet it actually made preventing COVID a little worse. But again, I don't know of any research that shows that fish is beneficial or necessary for human health, right? There are many people who eat whole food plant-based, don't eat fish, who get all of the benefits, the China study. So we looked at it a little bit, but there's much more research out there. The real question in my mind is not, do you need fish? No, you don't need fish in your diet. And there are non-fish, non-animal sources of omega-3s. And part of the problem, to be honest with you, why we have problems with people who eat the American diet is because you get too much omega-6s, which blocks the enzyme that converts your omega-3s. And so so you got to get more omega-3s in your diet, basically. And so when you start avoiding olive oil and processed foods, you don't have that problem. You produce your own omega-3s. If you get a little bit in your diet, the precursors, you do enough on your own. So the question in my mind is not, do you need fish in your diet or any other meat or processed food, but how much can you get away with without having a negative effect? Right now, that is the question, right? We know you don't need it. A lot of people will go without it. Maybe you can get away with some. That's what people want to know, right? And you have a question?
Please fact check, because this is from a couple of years ago. I think it's from a Force Over Nines was the source. They were talking about actually fish actually don't need they get algae. So you can actually get algae. There's something about how it's word to go get pulled up or something. So you just get fish.
Also, Dr. Esselstyn, you can go to his website, just search Dr. Esselstyn, and he's got a lot about omega-3. You can read some more there, and probably also, I think also Neil Bernard has something on that website too, so it's question and answer section. Yeah. So there's a lot of components to meat that make it unhealthy. The animal protein for one, but also the fat and saturated fats and cholesterol, right? So the person who's adamant, it's just like the smoker, I cut down, I'm down to 2 cigarettes a day, filtered. Well, what do you say to that person? Good job. It's not an all or nothing. The better you do, the better off you are. So we're always cheering our patients on. You're doing great. But if you want to do better, here's what you do. I tend not to recommend lean meat is the answer, right? No bigger than a deck, small portions, 3 times a week is, I think, the DASH diet, for instance. So if you want, eat it less, small portions, lean meat if you have to do it, not red meat, not processed meat, right? Most of the cholesterol in the American diet, as I understand it, comes from chicken now, because everybody's, oh my God, I got to change to healthier meat. Well, it's not healthier, it's less unhealthy. Still has a lot of cholesterol in there too. So just keep educating them, keep working on them, but always cheer them on for what they did do. That's important. And get them into group education, because they hear everybody else talking about it. They're like, I don't need to do that anymore. Good question, thank you. What about the patient who still wants to eat meat? That was a question. I apologize for not repeating it. Any other questions? And I'm here too, if anybody wants to come up after and ask any questions. I thank everybody again. And I'm available if you come up with something later. So thank you for having me, everybody.
Thank you again, Dr. Dubay. Great talk.
Thank you. I'm not sure how to turn off the recording. Great deal.